Just getting started. Again, my name is Rachel Perkins. Welcome everyone to the Texas Oncology Foundation, the Survive and Thrive webinar series. We're glad to have you all with us today, and we're excited to hear from Sara Mokhtary. She's discussing genetic testing for hereditary cancer. So just to give you a little bit about the Texas Oncology Foundation, we're dedicated to providing support to cancer patients in the communities where they live, work, and receive treatment. Sara actually works for Texas Oncology, and she also believes in that mission as well. So through Survive and Thrive programming like this one, the foundation is able to provide educational events and resources to both help build a community, connections, and support all that are involved on their cancer journey. So that's what we're here for you guys today. So without further ado, let's introduce our speaker. We have Sara Mokhtary here today. She's the Regional Genetics Program Coordinator for Texas Oncology in San Antonio. And she's going to be talking about genetic testing for hereditary cancer. So Sara, go ahead and take it away for us.
Thank you so much, Rachel. I'm just going to go ahead and share my screen. Awesome. Well, good morning, everybody. I am just so excited to be here today and talking about a subject that I feel so passionately about. So I really appreciate you taking time out of your day to join. Like Rachel said, I am a regional genetics program coordinator for Texas Oncology in the San Antonio region. So I help manage the San Antonio genetic testing program for our 10 San Antonio and Hill Country locations. However, we are so happy to have a really robust genetic testing program across the state of Texas through our Texas Oncology Clinic. So if this is something that you're really interested in, rest assured, wherever you are in Texas Oncology, you're probably very close to a genetics provider. So I wanted to, before I even move further, introduce myself in terms of what I actually do and what I actually am. So I am a certified genetic counselor. That's what that CGC stands for. And some people have just never heard of a genetic counselor before. So I like to define what that is. We are master's educated healthcare providers. We go through a graduate program learning all about how changes in a patient's DNA affects their health and their risk to develop certain diseases. So we're a really integral part of cancer care because more and more patients are really benefiting from genetic testing. So without further ado, what we'll be going over today is who should consider genetic testing. This is, I think, the number one question we get, not only from patients, but from providers. So we always like to make sure that we're empowering patients to know if you are a good candidate for genetic testing. We'll also be talking a little bit about what type of information you can learn from a genetic test. So genetics is unique, as we'll talk about a lot today. It doesn't just affect the patient, it also affects their family members since we share our genes with our family. And lastly, we'll be talking about how a genetic test result can change medical care. I get this question a lot when we're with patients. They're like, okay, well, that all sounds good, but let's say I find out I'm positive, or let's say I find out I have a mutation. Is that just going to cause me anxiety, or is there something that I can actually do with that information? So we'll definitely talk about that today. And the last part of today's presentation is my personal favorite. There are so many myths about genetic testing that we still hear on a daily basis from our patients. And so that's where we'll go over some of the common questions and misconceptions about genetic testing. And I posted it in the chat, but I absolutely love questions, especially in a webinar setting where it feels like I'm just talking to myself. I know you all are out there, but if you have a question, just don't wait to the end to type it in. Just type it in that chat, and Rachel and the Texas Oncology Foundation team will help me out at the end of the presentation to make sure we can get all of those answered. Okay. So before we dive into genetic testing and hereditary cancer, I think it's important we all level the playing field and make sure that we're using genetics terminology in the same way. Genetics has become a real buzz topic in the last decade or so. Without fail, every year, Black Friday, one of the most popular gifts are like Ancestry DNA kits or 23andMe kits. And I feel like everywhere you turn, there's always that genetics buzzword popping up. And so I like to make sure we're just defining some of these terms. So we'll start out with the very basics. What is a gene? So I really like to think of our DNA as a big instruction manual for our body. This instruction manual helps our body grow and function normally. So if we think of our DNA as the big instruction manual, we can think of genes as the individual pages of that instruction manual. So we have over 20,000 genes in our DNA. And they all typically provide a specific instruction for a specific protein that does something in our body. So it's not surprising that when we're talking about hereditary cancer, we're looking at genes that are really important for preventing cancer or for preventing tumor growth in our bodies. So I always like to make that clear. Sometimes you'll hear individuals say things like, I have the BRCA gene, and that's a little bit of a misnomer. So we actually all have these genes. What we're looking for are changes or mutations. You can also think of these as typos in those specific genes. So this is really what a genetic test is looking for. When we do a genetic test, that's typically blood or saliva. The testing labs are essentially doing a really thorough spell check of all of these different genes that we're looking at. And what we're looking for are just, like I said earlier, typos, little changes. Now, I think it's really important to point out that genetic testing will often find little typos, or sometimes we call them variants, that are not harmful. So variants are such an important part of just what makes all of us a little bit unique, right? Are you somebody that hates the taste of cilantro? That's a genetic variant. What color are your eyes? What color is your hair? All of these are genetic variants, and they're not all bad, right? But when we're talking about the genetic testing that we're doing in a clinical setting, we are really looking for typos or mutations that we know increase the risk to develop cancer. This maybe brings some of you back to high school biology, but it's important to know where our genes come from. Where does this big instruction manual, where is it printed? Where does it come from? So we do get all of our genetic information from our parents. So if we're thinking about genes as individual pages, we can think of chromosomes as chapters in our instruction manual. So there's 23 chapters. In all of these sets of chromosomes, we get one from our mom and one from our dad. So when we are talking about family history, a misconception is that maybe mom's side matters more when it comes to breast cancer, or and that's incorrect. So because we get half of our genetic information from each parent, both sides of your family history is so important when we're talking about genetic testing. All right, so when we are talking about genetic mutations, so these are harmful typos in those genes that we know increase cancer risk, those are inherited from a parent. And so again, before we jump into any of the specific syndromes or specific genes, it's important to know how these are passed on. So when we have an individual who has a mutation in a particular gene, each child they have will have a 50% chance of inheriting that mutation. It does not matter the sex of the parent or the sex of the child. So mothers can pass mutations to sons, fathers can pass mutations to daughters. It is independent of gender in terms of how these mutations are passed down through a family. One thing that we hear very frequently is, oh, the cancer skips generations in my family. So it's important to know that gene mutations don't skip generations. So if I have a mutation, then that's something I can pass on to my children. If I don't have a mutation, there's no risk that my children are going to suddenly have a mutation that comes out of nowhere. So we don't see these gene mutations skipping generations. Okay, so now that we've got some of the basic concepts and the basic lingo out of the way, I want to jump into the real focus of today, which is what is hereditary cancer and why is it so important? So this is my absolute favorite pie chart. If you come to Texas Oncology for a genetics appointment, there's a really good chance you'll see the same pie chart. But this pie chart really represents all cancer diagnoses. So we know that the large majority of cancer is what we call sporadic. This is likely due to a combination of many factors. It could be environmental exposures, it could be lifestyle factors. And unfortunately, one of the biggest risk factors for cancer is just aging, the aging process. So you can really see that's the majority of cancers that we see. Up to 85% of cancer is really sporadic. However, the smallest piece of the pie is what we call hereditary cancer. So that's anywhere from 5 to 10% of all cancer diagnoses are due to a specific mutation in a specific gene. And so that's what I was just talking about, in that if there is a mutation, that can be passed down through different generations of a family and can be increasing the risk to develop cancer. This is where we're really going to focus a lot of our attention today, is hereditary cancer. Now, there are definitely families out there that come into our clinics and they have lots of cancer in their family. But when we do genetic testing, we don't find any mutations. This is what we call familial cancer. We know that something's going on in this family. We just don't have a specific genetic explanation for why that is. We haven't found the answer to what's causing all of the cancer in that family history. So you might be thinking, okay, Sara, I get what you're saying about hereditary cancer, but it's the minority of cancer. Why should I care about this? And that's a good question. So why is testing for hereditary cancer important? There's a few reasons, but I would say the number one reason for a cancer patient is that knowing about any inherited mutations can really help care for cancer patients. So we've come so far in the last decade in terms of our knowledge about hereditary cancer that there are now certain drug therapies that can be utilized in cancer patients with mutations, and this can absolutely affect surgery decisions as well. We'll talk a little bit more about that. The second important reason why testing for hereditary cancer is important is that it can really empower healthy patients who have an increased risk for cancer to do something about that. So if we identify a mutation in a healthy person, right, who just maybe has a really strong family history of cancer, we know what their cancer risks are, so we can do something about that. We can send them for screening earlier, or we can make sure that they're getting screened more frequently than the general population. This goes hand in hand with identifying at-risk family members. So sometimes we'll unfortunately see patients who are very sick or who are at the end of their cancer journey, and they pursue testing, maybe not because that information will help them, but because that information can be so important for understanding the risks to their family members, particularly their children and siblings. So if we really boil down all of that text into one word, testing for hereditary cancer can really, really help with prevention of cancer. And that's something that is so, I think, important and really empowering to patients and their family members. So this brings us to really our first question that I wanted to cover in today's presentation. Who should actually consider genetic testing? So this image that you see on the screen is called a pedigree, also known as a family tree. And the numbers that you see in all those circles and squares is the degree relative to the individual. So for example, my brothers and sisters, mother and father, and children are all first degree relatives to me. When we start talking about second-degree relatives, we're thinking about grandparents, aunts and uncles, nieces and nephews. And when we start talking about cousins, those are third-degree relatives. It's really good to know about your first, second, and third-degree relatives. That's usually what we'll be asking for in a genetics appointment. If I could give one word of advice to all patients, regardless of your level of knowledge about genetics or whether you think you qualify, whether you even think you want to do the testing, the first step is knowing your family history. It can be so important, especially if you have a genetics appointment scheduled. This is usually the first thing we do in a genetics appointment is we sit down and we draw out one of these pedigrees. So I like to remember the 3 W's when it comes to family history. So the first thing you want to be knowing or asking your family members is who has had cancer and how is this person related to you, right? Is it your grandmother's, sister's, child's, daughter? How are they related to you? What side of the family did they fall on? The second W is what type of cancer did they have? And this is also related to the question of where did that cancer start? We know that sometimes cancer can spread or metastasize to certain parts of the body. In genetics, we really want to know where that cancer started. And the last W is when. When did that cancer occur? How old was the individual when they were diagnosed with the cancer? So if you are talking to your family members, remember the 3 W's. Having that information will make your genetics appointment so much more valuable because it really allows us to see what all is happening in the family tree. Okay, now I tend not to like slides with so much text, but this is actually a screenshot of all of the different red flags that we have for testing in our patient brochures. So you might see these at some of the Texas Oncology offices you visit. I believe it's also on our website, but we know that patients have a lot of questions about who qualifies for genetic testing. So we wanted to put together a handy little cheat sheet for that. Now, big misconception is that genetics is most important in individuals with a personal or family history of breast and ovarian cancer. That's not true anymore. So as you can see, looking at this list, there are lots of cancers with a genetic component. So yes, female breast and ovarian are very important, but pancreatic cancer patients, metastatic prostate cancer patients, colorectal patients, and even kidney cancer patients. These are really important red flags to be looking for, again, in your personal history or in your close family members. So this brings us to our second question. Okay, we now know who might be a good candidate to consider genetic testing, but what is that test actually going to tell us, right? What information can we really gain from doing a genetic test? So one thing that I always like to tell patients is that, unfortunately, we are not fortune tellers. There's no way we can do a genetic test and say, yes, we are certain that you are going to develop this type of cancer. That's not how genetic testing works. What a genetic test will tell us is if we find a mutation, that tells us that the risk for certain types of cancers is higher than the general population. So on the flip side, if you have a genetic test that does not find any mutations, that does not mean that your risk of cancer goes to 0. Unfortunately not. It just means that you're, back at that general population risk for cancer. So you're still going to want to do all of your preventative screenings, pap smears, colonoscopy, annual skin exams. But if we know that someone's at a very increased risk for developing certain cancers, that's when we start to really change medical management. Now, there are 3 different types of results that we can get from a genetic test, and one of them is a little tricky. So I want to cover all 3 possible results from a genetic test. So the first that I mentioned, I think, is the most straightforward. It's a positive result. We found a mutation in a gene. We know this means that your family members are also at risk to carry that mutation. We know that this increases cancer risks. And it can also explain why someone developed a certain cancer. So we know that for cancer patients, that can be one of the hardest questions is, why did this happen to me? And so if we do find a positive result, in a lot of cases, that can explain why that cancer developed in that individual. Like I was saying, on the flip side of a positive is a negative result. So we typically think of negative results as good news. We didn't find any harmful mutations. It doesn't mean the cancer risk goes back down to zero, but it maybe means that we don't need to be as concerned about a significantly increased risk to develop cancer. And lastly, this is this tricky result where if those of you on the call have maybe had genetic testing, you may have seen this terminology. We call it a variant of uncertain significance. That's just a really long way to say, we did find a little typo in your genetic code, but we don't really know how that affects cancer risk. Variants of uncertain significance are super, super common. Most individuals have these variants. And if we think back to the very beginning of the presentation, variants are not all bad, right? Variants are what make us a little bit unique, a little bit different. Not all variants are harmful. So if you get a variant of uncertain significance on your genetic test result, we do not treat that as a positive. We treat that as a negative result. So we don't typically change, screening recommendations or surgery recommendations. We'll say, give us a few years, let us learn a little bit more about this variant, and we'll call you with updated information. But the large majority of the time, these do not affect cancer risk in any way. So I want to dig into two of the major genetic syndromes that we see in the hereditary cancer space, just to give a little bit of a framework of how a positive result might change care. So those of you may remember in 2012, 2013, Angelina Jolie really made national news because she came out and said that because of her mom's personal history of breast and ovarian cancer, she was tested for the BRCA1 and the BRCA2 gene. She was found to have a mutation. I always forget if it was BRCA1 or 2 that she had the mutation in, but she does have a BRCA mutation. And because of this, she underwent a bilateral mastectomy where she moved both breasts and had reconstruction. And she also had her ovaries removed because of this gene mutation. So after this, the demand for genetic testing went through the roof. It really, really brought a lot of awareness to genetic testing. So you can see on the bar graph that these are all of the different cancers that we see associated with the BRCA1 and BRCA2 genes. I like to point out, it's not just breast and ovarian cancer. So sometimes we'll see our men with metastatic prostate cancer and they're like, why am I being tested for the breast cancer gene? And we're like, yeah, they weren't named very well, but these genes actually increase the risk for many types of cancer that are important for both women and men. You'll notice that the highest risks are for female breast and ovarian cancer, which is why we typically recommend increased breast screening or mastectomy. And the ovarian cancer risk is so significant that we do recommend removal of the ovaries. I'll talk a little bit more about that in a moment. The other syndrome that I always like to highlight is Lynch syndrome. I'm so curious if any of you have heard of Lynch syndrome, because it's actually a lot more common than BRCA1 and 2. It just hasn't received the same media attention. So Lynch syndrome is the most common hereditary colon cancer syndrome, where we see up to 1 in 20 patients with colon cancer have Lynch syndrome. You can see in the orange picture, there's lots of different cancers that we see associated with Lynch syndrome, the highest risks being for colorectal and uterine or endometrial cancer in women. So this is another just example or reason why it's so important when you're asking your family members about family history to not just focus on breast and ovarian cancer, but to really ask about all types of cancer, because there's lots and lots of different genes that are related to lots and lots of different cancers. Another misconception that I really like to address, because we see patients that come in all the time and they're like, I'm here to be tested for the breast cancer gene. And this kind of goes to show how much we've learned in the last decade. When I graduated graduate school in 2014, we were maybe testing for like 10 to 15 genes. Now, some of the tests that we order have upwards of 50 different genes. And all of these genes are related to lots of different types of cancers. So you see that if someone has colorectal cancer, we're not just testing them for Lynch syndrome. There's lots of other genes that are linked to colon cancer. And similarly, if someone comes back with the BRCA mutation, we're not just worried about breast cancer. There's lots of other cancer risks that we want to be knowledgeable about. So typically when we do a genetic testing appointment or a genetic counseling appointment, we're not going to talk about every single gene and every single risk because we'd be there for a very long time. But we do, if anything, of course, comes back positive, really do a deep dive into that particular gene and the particular cancer risks that are increased. So I've been alluding to this, but I want to do a little bit more of a deeper dive into how does this really change care, right? If we find a positive result, what are we going to do with that information? So the first thing that can really, really change is screenings. So in the general population, we all know women should be having annual mammogram starting at 40. Colonoscopy starting at 45, and then based off those findings, the GI doctor will tell you, when to come back. Usually it's somewhere between 5 to 10 years between colonoscopies. But there are some very important screenings that we would implement for certain cancers based off of a positive genetic test result. So breast cancer is a really good example. If I know that somebody has a BRCA mutation, I don't want to wait till 40 to start screening them for breast cancer. We really want to actually start screening them as early as the mid to late 20s. Again, BRCA is an example. Every gene's a little bit different. So that's the first thing that you might see is we might still utilize screening methods like mammogram and colonoscopy, but just start them earlier than the general population. The other thing that we might do is use alternative screening technologies. So we know that mammograms are really good screening tools, but particularly in younger women who tend to have denser breast tissue, an MRI may actually help us detect even smaller cancers. So for individuals who are at a significantly increased risk for breast cancer, we may implement MRI in addition to mammogram to make sure that we're trying to detect those cancers at the earliest stage possible. Same goes for colonoscopies, right? Rather than waiting 5 to 10 years between a colonoscopy, in Lynch syndrome, we sometimes wait, 1 to 3 years between a colonoscopy. Those tumors can grow so quickly that we don't want to give it time to develop. Now, for certain cancer types, we don't have good screening. I think the best example of this is ovarian cancer. There is really no effective screening for ovarian cancer, unfortunately. So if we remember our bar chart for BRCA, those ovarian cancer risks can be up to 30–40% lifetime risk. Without screening, that's a bit of a gamble. And so it's not uncommon that if someone has a high risk for a cancer like ovarian cancer, that we would recommend prophylactic. So that word essentially means we would do surgery before we even know that cancer is there. We're going to take the ovaries and fallopian tubes out preventatively. Another thing we hear from patients, I've heard this before, they say, I don't want to have genetic testing because I don't want to have a mastectomy. And that's okay. Thankfully, we have really good screening for breast cancer. So while some women with mutations do tend to have bilateral mastectomy, again, depending on the gene, that's a consideration. It's not a strong recommendation because we have a good screening tool for breast cancer. And lastly, I mentioned this a little bit earlier, but there are certain genetic mutations that can help target therapies or drugs for patients with a current cancer diagnosis. And so this is something that you'll hear, maybe your oncologist or your surgeon will say, well, you have this, you have ovarian cancer. If you have a BRCA mutation, I could utilize, this drug. So we want to pursue testing for that reason. So not for every mutation, but we are learning more and more about how we can really target therapy based off of genetic mutations. And there are clinical trials that are available as well based off of mutation status. So for individuals looking for clinical trials, this can sometimes help with eligibility for that. Okay, I'm going to go back for one moment. So again, I really encourage you, if you have questions about anything so far, please post it in the chat. I really love answering questions. As I mentioned at the beginning of today's presentation, there's lots of misconceptions we hear about genetic testing. And so I wanted to format this in a way of common things we hear from patients or common misconceptions so we can really bust some of those myths. So that'll be the last portion of today's presentation before we answer some questions. So my first one that I always love to bust this myth is genetic testing is expensive. We hear this one a lot, and it always breaks my heart when I hear patients say, well, I didn't want to do testing because I was worried I wouldn't be able to pay for it. So thankfully, in the last, again, I would say 5 to 7 years, we've really seen the cost of genetic testing plummet. So while genetic testing used to be very expensive, the cost has significantly decreased. We now tell patients that oftentimes the worst case scenario is $250 for genetic testing. Now, I know $250 still may seem like a lot of money, and it's still a lot of money, but I don't want you to interpret this as testing is $250, not at all. We do see that patients meeting genetic testing criteria, so, having earlier ages of onset of cancer or multiple generations with cancer, those individuals tend to have very good coverage for genetic testing. Most of our cancer patients at Texas Oncology pay less than $100 for genetic testing. And that's something that, again, based on your situation, your personal and family history, and your insurance, a genetics provider can help navigate the financial aspect of genetic testing. But we always tell patients, don't let cost be the reason you don't book a genetics appointment. A lot of the labs that we work with do also offer really generous financial assistance programs. So there's a lot in place to make sure whoever needs testing can really have access to that testing. All right, next myth that I like to bust. So genetic information can be used by insurance companies to discriminate against patients. So this is a little bit of a tricky one. It's a little bit true and a little bit false. So there is a law we call GINA for short. It's the Genetic Information Non-Discrimination Act. It's quite a mouthful, but essentially GINA says that patients are protected from discrimination from health insurance companies and employers. So basically, if you have genetic testing and you come back with a mutation, Cigna or Aetna or Blue Cross, they can't say, oh, because you have this mutation, we just don't want to cover you anymore, or your monthly rate is going to go up. That is illegal. However, GINA does not apply to other types of insurances like life insurance, disability insurance, long-term care. So sometimes we tell patients who are young and healthy and don't have cancer, if they're really concerned about getting things like life insurance, that they pursue that before they have the genetic testing done. Just if, again, if it is a concern for them, then they at least have a life insurance policy in place before they pursue genetic testing. So that's important to know about discrimination. But typically we want patients to know that health insurance companies, that's an absolute no-no for them to discriminate. Okay. Hopefully you all know the answer to this one based off of what we talked about already, but we sometimes do hear from patients, I have advanced disease, I already have cancer, what's the point of doing testing, or, how is that really going to help me? And so, like we've already talked about, having a positive result can sometimes help explain why a cancer developed, which can be really important just for psychological health for cancer patients. We also know that knowing about a specific mutation can change medical management, surgery planning, different therapies and drugs, even clinical trial eligibility. And of course, going back to our family tree, we share our genes with our family. So if we do find a mutation, that can be really, really helpful for other family members to understand their risk. This is a big question that we get, especially amongst individuals who maybe don't know their family history, don't have a close relationship with family members where they feel comfortable asking about family history, or adopted individuals who just don't know anything about their family history. They say, well, can I still come to my genetics appointment even if I don't know my family history? The answer is absolutely yes. I always tell patients when we ask all those family history questions, it's not a quiz or a test. We're just trying to ask the information that you know about. If you don't know, or if there's no way for you to know, of course, that's okay. So we'll definitely talk about the most appropriate testing options and, the best ways for things to be covered by insurance. But like I mentioned on the previous slide, $250 is a pretty universal price that patients can pay for a hereditary cancer genetic test. So even for adopted individuals who are just curious, there are definitely options for them to understand their cancer risk as well. All right, another question that I really like answering. They say, well, Sara, what's involved with a genetic test? Like, how easy is this going to be? And we especially know for cancer patients, you're coming to Texas Oncology a lot. You have chemotherapy appointments. You have all of these appointments. We know it's another appointment. And so we do try to make it as easy as possible. So I would say, generally speaking, genetic testing is pretty easy. And that most of the time, we're just taking a tube or two of blood. And it's non-fasting, your DNA does not change with what food you eat in the morning. So in that sense, logistically, it's easy to do a genetic test. However, the only caveat that I give to that is that we also have these genetics appointments so patients can really understand what type of information they can learn from this testing. We know that the cancer journey is a roller coaster, and sometimes it can be really challenging for patients to find out they have a mutation. In talking to their family members about that, there can be feelings of guilt in terms of, passing something on to a child or to a relative. And so that's the only thing where I say, yes, it's easy, it's a blood draw, but it's a little more than just a blood draw, right? It's really information that can have a pretty significant impact. So we want to make sure that patients really understand, what they're getting themselves into and what information this test can tell them. Another fun one. Genetic test results from saliva aren't as reliable as blood. I worked for a genetic testing lab during the COVID pandemic, and we had a lot more saliva samples coming in because patients weren't going to clinic. And we got this question a lot. Patients would come back with a positive result on saliva and not believe that result. So I'm here to bust that myth that blood and saliva are both great options for genetic testing. So if you do a genetic test on saliva, it's looking at the same DNA that would be in your blood cells. So we are looking at white blood cells, and those white blood cells can be found in on your cheek as well as in your blood. We do tend to say that blood draws are the preferred method just because it's easier. There's a lower fail rate with a blood sample. However, if you do submit a saliva sample and get a report back, you can trust that report. It's just as reliable as a report that you would get from a blood test. A note for patients who may have had a bone marrow transplant or a stem cell transplant from a donor. We can't do blood in that case, or saliva, because we can't really tell if those white blood cells came from the patient or from their donor. So in some very rare situations, we have to do a small procedure to get a little punch of skin to get the DNA from your skin cells. That's very rare. Like I said, that's for patients where the blood is not as reliable. But generally speaking, blood and saliva, both good options. All right, I think we're coming to the end of our myth busting. So 23andMe, I think, is a really fun company. They have definitely put genetics and genetic testing on the map. They got people interested in genetics. However, 23andMe is just that. It's a fun company. It's something that you want to, that's fun to do if you're curious about your ancestry, or, different traits, physical traits, like the cilantro one is definitely on that 23andMe report. However, we do not make medical decisions based off of 23andMe reports. You would be surprised how many patients we come in with the 23andMe report and say, well, I'm positive, so I'm ready to schedule my mastectomy. And we're like, not quite. So 23andMe testing is very bad from a clinical perspective for two reasons. Number one, even though they do some BRCA1 and 2 testing, it's really only looking for 3 variants that are very unique to the Ashkenazi Jewish population. So if you are not Ashkenazi Jewish, doing a 23andMe BRCA test is really not going to be beneficial. The other thing that is kind of scary is that labs have done research looking at patients who did have a positive result on a 23andMe report. When we confirmed that with a reliable clinical grade lab, how many of them actually did have a true positive? And that number was really low. So of 23andMe reports that were issued that said you have a BRCA mutation, most of those were false positives, which means that if a woman were pursuing, different surgeries or screenings based off of those results, that was completely not warranted. So moral of the story, 23andMe, super fun if you, are looking to okay, apologies. Gotta love technological difficulties, so I hope everyone can still hear me. Bottom line is, with 23andMe, super fun, but we don't use this for medical decision making. That's something we'll always confirm with a medical grade level test. All right, I think we maybe have 2 more myths. Pursuing genetic testing is always a choice. This is an absolute yes. So when we have a genetic test appointment, and we know sometimes in those conversations with your providers, they'll say things like, I'm sending you for this appointment to have the testing done. It's a choice. So like we talked about earlier, we want to make sure that patients really want to know this information, feel that it's the best time for them to have this information. So coming to an appointment does not mean we're going to drag you to the lab and make you get your blood drawn. Not at all. We're going to give you the information. We're going to take your family history, and we're going to talk about the options. But if it's something that you're not ready to do at that time, that's completely fine. I think this is my last one, a very important one. So this will happen where, let's say we identify a young man or a young woman who tests positive for a mutation, and they have minors, they have children who are under 18. They often ask, well, can I bring my kids in and can they get tested? So someone told me this analogy recently and I loved it. You're hard pressed to find like a tattoo artist to give a tattoo to a minor, right? And I think there's a lot of reasons behind this. Tattoos can be really beautiful. It's not that tattoos are inherently bad, but we also want to make sure that an individual who is doing that is really at an age of emotional maturity to make that decision for themselves. This, like a tattoo that will stay with them forever, their genetic test results will also stay with them forever. And so because so many of these genes are associated with adult onset cancers, we really don't see many of the genes having childhood cancer risks. We strongly recommend that children wait until they're older than 18 to pursue genetic testing, just so they can have that autonomy to make their own choice, and to make sure, like we talked about with insurance discrimination, that if there are concerns about life insurance or long-term care, that they can have that in place before they have the testing. Okay. So if after this, you're like, okay, I have family history, I have a personal history, I'm really interested in genetic testing, I have good news for you. So again, if you are within the Texas Oncology group, talk to your provider and ask for a referral. We have great trained or genetics trained providers at over 90 different clinics all across the state of Texas. We even have genetics providers in our virtual clinics. So if you are at a clinic that's just really far away from another clinic with a genetics trained provider, you can even do these appointments virtually. So this is really something I think can be so empowering to talk to your provider about. Oftentimes oncologists, surgeons, they're so busy, they've got so much that they want to talk with you about in your care, that sometimes genetic testing is forgotten. And so it can be really important to say, hey, I have this family history of, pancreatic cancer that I'm really worried about. Can I have a genetics referral? So we do have our a web page on the Texas Oncology site. You'll sometimes hear our program called the GREAT program. That stands for Genetic Risk Evaluation and Testing Program. But we are really more than happy to help facilitate testing for patients and really just walk them through the genetic testing process. So if you are interested, there's definitely providers here at Texas Oncology that can help facilitate that. So that brings me to the end of my presentation. Like I said, I love questions. So now's your opportunity. Please type them into the chat. And I hope that all of you have just learned at least one new thing that you can take with you and share with your friends, share with your family members. But again, Rachel, I so appreciate you being here and hosting me today. And I'm happy to take any questions.
So we do have a couple questions in the chat. Thank you so much, Sara, for just showing your passion for this and how you've really thought through your presentation. It is really a beautiful presentation. So we're going to move on to some questions from the audience. We've received a couple really good ones, but if you guys are still trying to type out or decide what your questions are, feel free to start writing those out now. And let's start with the first one. I have a participant asking if there are any specific companies you recommend or that Texas Oncology utilizes for genetic testing.
Yeah, that's a great question. There are a lot of genetic testing companies out there. And then the only reason why I'm hesitating to name any specific companies is, there's a lot of good, there's a lot of good ones. I would say, generally speaking, the three most common labs that Texas Oncology utilizes is Myriad Genetics, Invitae, and Ambry. Those are three real leaders in the hereditary cancer space. It doesn't mean that there's not other good options out there, but chances are if you visit a genetics provider within Texas Oncology, those are the three of the most utilized labs that we use.
Awesome. So I have another participant asking, do you need to do genetic testing every few years? And there's a little bit of a background to this. And she's saying she's asking because she got tested, was diagnosed with breast cancer, and then now all of her cousins are getting genetic testing done again after one of her aunts was diagnosed with cancer previously. So there's been 2 cancers within the family now. So people are getting tested multiple times. So do you need to do genetic testing every few years?
That is such a good question. I'm so glad you brought that point up. I should have actually addressed this in my presentation. So It really depends on the date that you had your initial testing and what genes were looked at. So if you remember that slide that had the list of all the different genes that we test for, we absolutely see women that were diagnosed with breast cancer 10 years ago. And the only two genes they were tested for were BRCA1 and BRCA2. So if the initial test was very small or very outdated, I tend to say like before 2010 or so is when the technology really started to change. That's when it can be really important to talk to a provider and ask about what we call update testing. However, the one distinction that I want to make here is our DNA does not change over time. So if let's say somebody's tested now and they're tested for 80 different genes, it's not like if they get testing for those same 80 genes next year that we're all of a sudden going to find a mutation. So I think that the specifics of that question will really just depend on how many genes you were tested for and if the BRCA testing technology was good at that time. And a genetics provider can definitely help answer that if you have a copy of your report.
Yeah, so it's almost like you have to bring in your copy of what you've already got tested, and then they'll test what you haven't been tested for yet.
Exactly. Great question.
Okay, so our next question is asking, are there any mutations associated with brain cancer that you know of?
These are all such great questions. So brain cancer is tricky. There are definitely some genetic syndromes that do involve brain tumors or tumors of the central nervous system. It's not as straightforward as, like let's say you have a mom who had breast cancer at 50, that's a really easy criteria for genetic testing. With brain cancer, it really depends on the other cancers that are in the family. So I mentioned Lynch syndrome with colon cancer and uterine cancer. One of the cancer risks that's smaller in Lynch syndrome is actually brain tumors. But it's not the cancer that we immediately think of with Lynch syndrome, but let's say we were seeing colon cancer and brain cancers in a family history, that's where we might, talk about testing. So I would say if there's brain cancer, my best advice would be get a really good family history of what else is going on in the family history and what type of brain tumor it was. There's so many different types of even non-malignant brain tumors. But I do think it's worth a genetic evaluation or talking to your provider about it, but it's not as straightforward as, breast, ovarian, colon, uterine cancers.
So we can wait just a little bit longer to see if anyone has any further questions, but everyone is saying that how insightful this is and how much information you have, and very thankful for you and how helpful you've been throughout this entire presentation. I know that you touched on a little bit of kind of like who should get genetic testing and things like that. And I think you did a really good job of doing the science portion, but also doing of like how this can affect you in the future. So since we are so close to Mother's Day, I did want to ask, what are your thoughts of mothers getting genetic testing and then finding out that they might have genes that they passed down? What would you say to a mom that's done that? And be like, should they have their kids tested or things like that?
Yeah, definitely. I think, it's funny if you follow any like genetic accounts on Instagram, our big holiday is Thanksgiving, right? Because what are you doing at Thanksgiving? You're sitting at the table with all your family members, right? So it's a really good time to ask that family history information. I think, it's a really it's in terms of like mothers and daughters, I think it's always important for families to be in open communication about the cancers that are going on in that family history and to have, open communication about that. One question that I like to ask patients, particularly if there's like a really strong family history, is, have you talked to your kids about this testing? Do they know that you're pursuing this? Because that can often be, I think, the hardest part is family communication about risk factors. We try to help as much as we can. At Texas Oncology, we have letters that we print that can be shared with family members, to help spread that news. Some labs will even offer free testing for family members within a window if there's a positive mutation identified. So part of why we really like to facilitate genetic testing and counseling with our providers is if there is a positive, the patient's our patient, or the patient is our patient, but the patient's family kind of also becomes our patient in terms of we want to make sure they have that information as well. So
just a couple more questions.
Yeah.
So I had a participant ask, is there a test for BRCA3 gene, or is there such a gene for that?
Good question. To my knowledge, there's no BRCA3 yet.
Okay.
But there are a lot of other genes that are related to breast and ovarian cancer. So you can maybe think of it as BRCA3, but it's not called that. One of my favorite genes to talk about is a gene called PALB2. And it actually stands for partner and localizer of BRCA2. So I kind of think of PALB2 as like BRCA2's best friend, you know? So a lot of these genes are still predisposing to breast and ovarian cancer, but that we know of, there's really only BRCA1 and BRCA2.
And last question, when you do genetic testing, is the results stored somewhere for future like use or for future comparisons?
Yeah, so with a genetic test, and this goes if you're pursuing genetic testing wherever you go, you should always get a copy of your results. If your provider is not giving you that copy, ask for it. They should be doing that. So I can speak here at Texas Oncology. We always give the patient a physical copy of that report, and we put a copy of that report into their medical record as well. So documentation is very important. Sometimes we do get like privacy concerns about, data sharing, things like that. Patients get a little bit confused because again, 23andMe, some of these labs, they're very open that they do share and sell some of, patient data. Medical grade labs do not. They really keep that information very private. So the only people that should have your genetic data are you and your medical team. And then of course you can share that with whomever you wish, but we will not be sharing it on behalf. I even have, daughters come in and they say, oh, my dad was tested with Texas Oncology. We do not even go into that individual's chart unless we have verbal or written permission that we are able to access those genetic test results. So yeah, privacy, we definitely take very seriously when it comes to this.
Okay, we have one more question. Hold on.
Yeah.
We've answered this in a Facebook Live before, and I just think that it's good to bring up. So someone asked, if you're doing adoption, where do you begin? So
yeah, it's a great question. I think for individuals who are adopted, we absolutely can see those patients in our clinic. Unfortunately, the insurance coverage for testing is sometimes challenging, if there's not known family history. But like, let's say someone has breast cancer at any age, really, and they're adopted. Absolutely, we can usually make a pretty strong case in terms of, well, this individual has cancer and we just don't know what the family history is, so we try to get insurance to cover that. However, if you're adopted and you're healthy and you just want to understand if there are any hereditary cancer risks, I think it's very well worth making a genetics appointment, but just being aware or okay with the fact that that may be something you would self-pay for, which again, those self-pay prices are right around $250 for a genetic test.
Okay. Awesome, Sara. Thank you so much. So thank you for everyone participating with us today. That was going to be our last question. Just a reminder that this session was recorded and will be sent out to registrants in a follow-up email. It'll be a link to our site, so you'll definitely get that right after this. And then you can share it with your family and friends as well. It'll be available on our website as well at texasoncologyfoundation.org. Then you hit the programs tab, and then you're going to go to the Survive and Thrive webinar. And it's just on the top left. You'll see the little archive page there. Make sure that you like our Facebook page. We actually did a live earlier that's on there that has some other questions that are answered as well. So if you're like, oh, I missed my question, then feel free to comment on there too. I know that we're both pretty active and might be able to answer you there as well. So like our Facebook page, Follow us on Instagram. Just keep current with the foundation and the programs that we offer here as well. And we do have some upcoming webinars. We have 2 upcoming webinars. One is on June 6th, so it's coming up. It's an intimate connection at end of life. That's the topic. So that's a pretty interesting one. I know everyone wants to know a little bit more about how that looks and how different people kind of go through that. And then on June 27th, because it is the middle of summer, we are going to do a skincare after chemo. So just talking about what your skin does during chemotherapy and how it acts years later after chemotherapy, and just kind of how to deal with that during the summertime. We also, since you guys have previously participated in the webinars, you are invited to do mentors and meetups with us. And it's a place to do peer-to-peer connection and develop deeper community connections. It's every Tuesday, every second Tuesday of the month. And we will do workshops and have speakers kind of like this. It'll just be a little bit more informal. And then lastly, we value your feedback. So let us know if this was important to you guys, if you loved this, if this didn't quite hit the mark. We want to know in order to offer you better information in the future. So you will be getting a link to a survey. So just take those a minute to 30 seconds to provide us information and your thoughts on the presentation today. And then share topics that you're interested in the future. If you're like, oh, wow, I need to know a little bit more about this genetics, then we will have Sara or somebody on our team come back and go deeper into it. Let us know how you felt about this, and we will see y'all in the future. So thank you so much for showing up today, and thank you so much, Sara. It was perfect.
Of course. Have a great day, everybody. Thank you again.
Bye.
Bye.